Renuka is an esteemed geriatrician, and we've been supporting Renuka's research for many years at the Basil Hetzel Institute. She's also the Clinical Director of Aged and Extended Care Services at the Queen Elizabeth Hospital. So please welcome Renuka. Everyone so far, except Stuart, has complained about the height of the seats. So. Oh yes. Not supposed to sit on the edge, Paul.
If you fall, you can come to the Falls Clinic.
Thank you. Yeah. Thank you. Dr. Stuart Callery. Stuart's a senior medical scientist within the orthopaedics department at the Royal Adelaide Hospital, and many of you will find this interesting. Specialises in hip replacement surgery, but he's not a clinician. He is a clinical scientist, a scientist who researches about the impact. And Stuart is also a Hospital Research Foundation Fellow. So please join us, Stuart. And lastly, off her deathbed, who had from having her appendix removed earlier this morning, Dr. Hannah Wardle, whose research focuses on cancer survivorship, pain, and is the head of the Supportive Oncology Research Group at South Australian Health and Medical Research Institute, and is also a Hospital Research Foundation Group Fellow. So first of all, thank you very much. Thank you very much for taking time out of your busy days. What I'd like to do, perhaps starting with you, Hannah, is if you could give us a rundown about a summary of your research.
Yeah, absolutely. So thank you, and can promise you all that I'm not fresh out of the hospital. The appendix was removed several weeks ago, so we're okay. My research really merges my two areas of interest, which is gut health and also cancer. So I'm really interested in how cancer therapies impact the gut environment, how it damages the gastrointestinal environment, and how this leads to both side effects that affect the gastrointestinal system, so things like diarrhea and constipation, sorry that this is our lunchtime, but also some side effects that are distant to the gut, so things like cognitive impairment and brain fog that we see in people who are undergoing cancer therapy. I guess I had a fairly linear path to where I am. I did my undergrad at the University of Adelaide. I spent a couple of years overseas after my PhD. And I returned here in 2020, and I now lead the Supportive Oncology Research Group at the University of Adelaide and SAMRI. And yeah, really we're all about improving the health and well-being of people affected by cancer and aiming to do this by controlling and mitigating the side effects of their treatment.
Thanks, Hannah. Impressive. Stuart, let's hear a bit about what you spend your day doing.
I'm the senior medical scientist at the orthopaedic department at the Royal Adelaide Hospital for a long time, and then I was fortunate enough to get a THRF fellowship, and what that allowed me to do was move to the university and create my own research group, but still in strong collaboration with the RA surgeons. And what we're focusing on is the outcomes of patients that are undergoing hip replacements, and in particular the mechanisms of failure and how to treat those patients that unfortunately do have complications. So the four main complications are dislocation, fracture, infection, and implant loosening. And when you do have a complication, unfortunately, quite often, obviously the patient's in a lot of pain, has mobility issues, and more often than not has to undergo a repeat revision surgery. And my research is focused on these patients undergoing repeat revision surgery. So we're focused on patients going the second, third, fourth hip replacement on the same hip. And that's where we're at. The unique thing about my program is we're monitoring patients with a very sensitive X-ray technique, and we can detect poor performing implant designs and surgical techniques at 2 years rather than waiting 10 years for the outcome. So we're trying to assess implant designs and surgical techniques at the earliest point possible.
Thanks, Stuart. Everyone went, oh, that didn't sound good, did it? Renuka, you want to give us a summary?
Okay, so I'm the professor of geriatric medicine at University of Adelaide, as well as the head of geriatric medicine at the QEH. So my research is aligned to the area of healthy aging generally. So I'm not sure if the people in the room are aware of this, but 2021 to 2030 is actually the United Nations Healthy Aging Decade. So currently my research is aligned in that direction, taking a lifespan approach towards promoting healthy aging. So we're looking at ways to promote healthy behaviors, and through that perhaps prevent things like frailty, other things that we refer to as geriatric syndromes like falls, dementia, so on and so forth. So what can we do earlier on in life? What good messages we can provide? And how do we get people to take those messages up? So that's the current focus.
So let's cut to the chase. What should people be doing to ensure that they're giving themselves the best chance of healthy ageing? You've got a program called Avoid.
Yep.
Tell us about it.
So I'd like to claim all things that I came up with that wonderful acronym, but that's not true. It's actually an acronym that the Canadian Frailty Network came up with, and it's after they'd done a lot of research and had a lot of consultation with stakeholders and consumers in Canada. So AVOID stands for several good behaviors. So A is activity. I'm struggling with that one, but A, healthy activity. V for vaccination. O for optimizing medication, so right drugs. I for interaction, which is what we are doing here today. And D for healthy diet. I hope the diet was very good. But the other good behaviors the program tries to promote includes things like falls prevention, sleep, and through the work of the WHO, vision and hearing is extremely important as well for good health.
So Stuart, let's talk about some stats to kind of reinforce the value of your research. 50,000 Australians have a hip replacement each year. 5% of these will fail within 10 years, and for those who have revision surgery, 30% of those will fail within 5 years. So does the risk of a healthy outcome, and you know, we then have to define what a healthy outcome is, but does the risk of a healthy outcome depend on how healthy you are going into surgery?
There are patient factors that can influence your outcome, but like you've just said, the majority of patients having their first hip replacement have a good outcome. They have their pain's instantly relieved, and they go on to function quite well. As I just said before, we're really interested in the revision patients, and these patients, one in 5 will have additional surgery within the first year. And as you can imagine, that's a disastrous outcome for the healthcare system because these patients keep coming back, and at their next operation, the unlucky patients that do require further surgery, keep their chances at their next operation decrease even further.
And so, just a question without notice, Stuart. The public health system seems to bear the burden of poor outcomes from the private health system.
Well, it's a very controversial matter, but my PhD student last week went back and audited the last 22 years of activity at the RAH, and the key take-home message is that all across Australia, the burden of revision hip replacement is only 8% across all hospitals. The burden at the Royal Aid Hospital is 55%. Now, not only that, half of those patients that require revision surgery, over half are admitted through ED. So we have no idea when they're going to come, and we can't plan for resources to be allocated for emergency admissions. On top of that, he also found that if it's your second, third, fourth revision hip replacement, you stay on average 24 days. Now that is 7 to 8 times longer than your initial surgery. Usually within 3 or 4 days you're discharged. So these revision patients are actually complex patients to treat, often requiring experts from outside of orthopaedic fields, and it's quite hard to discharge them safely as well.
So, in detail, the THRF funded project that you're doing at the moment, how would it, in the best case scenario, how is it going to improve the success rates?
I have two main programs.
We're not going to hold you to it, Stuart. We're not
I know.
This will be your cake.
Yeah, I know. I'll have to report it back to Paul later. But the two ways I'm trying to address it is, one, stop patients getting a poor performing implant in the first place. We've always assessed them using our specialised technique at 2 years. We've got 2 students trying to get that even closer to 6 months. Can we assess them at 6 months and prove that the implant is performing well, it's stable in its environment? We've got other engineer students and collaborations with the Netherlands and Melbourne. And what we're using is the imaging from my study, funded by the THRF. We're trying to create computer modelling programs that can assess implant performance even prior to being used in patients. And the reason these programs haven't been done previously is because people haven't had patient-specific images. So we've got CTs, RSA, very specific measurements of implant migration. And what we can do is build these computer programs, but actually use my measurements to validate how real the modelling is. So once they're validated, companies can then use it. The end game is that my modelling programs will be used by companies to test their implants before they're put into patients.
So how many groups globally are doing this sort of work, research groups?
My specific technique, there's only about 12 groups internationally, and Adelaide is the Australian centre for our technique. And our meeting, we actually have a bi-monthly meeting last week, and the other investigators are from Sweden, Norway, Netherlands, US, Canada. And the reason, thanks to Zoom and COVID mainly, we can all jump on Zoom, we can share some challenges that we're all experiencing in clinical trials, share our learnings, and try and improve our study designs to allow the other centres to improve as well, and hopefully fast track the development of a faster method to assess these implants.
And so, from the Hospital Research Foundation's perspective, one of the core principles now that we have when we advertise a grant round is to explain what sort of national and international collaboration that you'll undertake, so that you can get the best and brightest ideas from all around the world. So it's glad to see that's happening. Hannah, it's been a really interesting shift over the last decade or so. I mean, there's a few people in this room, including myself, that are cancer thrivers, and cancer survival rates are increasing, and that's a really good thing, thanks to research. But it doesn't necessarily mean that people are living a quality life post their cancer treatment. So there's a lot of side effects with treatment. Your ongoing disease impact, the drugs that you're taking, etc. And there's now a lot of focus on gut health. And so you're trying to marry the two together, aren't you? Can you tell us a little bit more about that?
Yeah, absolutely. So I think you hit the nail on the head in that we're really in an exciting time in terms of my field of research, which is supportive cancer care or supportive oncology, which is really all about managing the symptoms and side effects, both short-term and long-term, of cancer and its treatment. You know, a long time ago, I think supportive oncology, historically was really about keeping the person alive during their chemotherapy. Chemotherapy is a pretty crude type of medication. It's essentially a poison that's given to people, and so when it was initially used, there was a real risk that people would die as a result of this chemotherapy. So supportive care was really, let's prevent the potentially fatal side effects of cancer therapy. If we fast forward to now, we luckily are in a time, as you mentioned, where cancer survival rates are the highest they've ever been. There's absolutely still work to be done. I'm not suggesting we've ticked the cancer treatment box, But absolutely, we are seeing people live much, much longer, either with a cancer diagnosis that's manageable or beyond a cancer diagnosis. And what we're starting to, identify in these people now is that about 30% of these people have an ongoing physical or psychosocial impact of their cancer treatment that affects them on a daily basis. So this could be brain fog that prevents somebody from going back to work. It could be persistent diarrhea that prevents people from socialising. These are really big problems that cancer survivors are facing, and they really shouldn't be forced to live a life that is disadvantaged by their life-saving therapy. So, as you said, I'm really interested in marrying my two interests, which are gut health and cancer. And we're really looking at how we can better support cancer survivors by promoting resilience in the bacteria that live inside all of us, which is our microbiome. So we all have about 500 grams of bacteria in our large intestine. It's about the equivalent of a left lung. And cancer therapy is pretty damaging to these really important bacteria. And the evidence that we've generated has shown that the worse the damage to these bacteria, the more likely cancer survivors are to experience adverse effects of their treatment. So our goal is to find ways to better support gut health, both during and after cancer therapy, and hopefully improve the quality of life of people who are living either with or beyond a cancer diagnosis.
There's such a big focus on gut microbiome. To the layman, it has the potential to be the next big thing. Professor Madden was talking to me earlier today about the impact of gut microbiome on people with pancreas cancer. It is really, there's a lot of so much effort going in to move the dial in this space, and it's really exciting to watch. Renuka, frailty. First of all, in one sentence, describe frailty.
I'm an Indian. I cannot do things in one sentence. So
I didn't ask about
impossible.
your cognitive function. I just said.
So frailty describes a phenotype.
This is a question without notice. She didn't get this question.
So it's what we see. So clinically, what it describes is people slowing, people getting weaker, people doing less activity, people saying that they're exhausted. And these are the features, and losing weight. So these are the features of frailty.
And so as a geriatrician, what sort of advice, and with all of the appropriate disclaimers, what sort of advice would you give about improving your cognitive skills?
Okay, so we're getting into this dementia, preventing dementia. Well, the good news is that acronym works, even for dementia. So it's actually good lifestyle choices. So things that you can do is lifelong education, that's a plus, social interaction, attending to all the vascular risk factors, so, obesity, hypertension, high cholesterol, diabetes, managing diabetes well. Trying to not get depressed if you can, or if you have depression, then attending to that. Sleep, some evidence there. There's actually, the Lancet put out that air pollution is bad. Not sure how you'll avoid that, but at least Adelaide's a good place to be in terms of air pollution. Hearing is important. So those who need hearing aids, please wear them. Hearing impairment is actually quite common. So I often have people saying, bringing their hearing aids in their bags. So no, please wear them if you need them. But if you haven't had your hearing tested, then get it tested as well, because you could have hearing impairment. And so there's a reason for doing well with that. But otherwise, the avoid acronym works, which is the hardest to use: activity and healthy diet, I think.
Yep. And for those of you who are interested, I will give a plug for our Body Brain Fitness studios, one on King William Road and one on Woodville Road. Our exercise physiologists would be happy to see you and put together a program for you, either as an individual or as a group. Really good facility if you haven't tried it. But there are other places around the city where you can go to specifically if you're worried about frailty and you want to put a bit of work into it. Some of the things that they do are quite challenging. So you're doing physical exercise while you're doing cognitive exercise. So I would strongly recommend that people that are worried about it sort of go and do it. Stuart, if you're successful, the economic benefits from outcomes of your research, less revision surgeries, less pressure on the system, is that also going to be part of your research reports?
It is one part of the program. We've got a clever student calculating all of the costs of hip replacements, not only in Adelaide but across Australia and New Zealand. And his early studies have shown that the average cost of your first primary hip is at $25,000, but the cost of revision on average is $80,000 per surgery. And what can we do about that is his next challenge. And looking at the data, it's actually amazing how many patients have multiple surgeries within one admission or get cared by more than one team. And we feel that some of the costing mechanisms are actually undercosted for those revision patients. So he's, in the next 2 years, he's going to get his teeth into what he can do to try and improve not only the reimbursements received by the hospitals for the care provided, but hopefully spread the knowledge of the true cost of these patients, because it goes well beyond, that's just the cost for the hospital admission. Of course, it goes well beyond with allied health care, care is provided, and cost of the family and everything post hospital admission as well.
So let's change focus a little bit. Hands up, who likes gardening? Who likes gardening? Right. Well, I was watching my partner out in the garden this morning, tending to a tomato bush that doesn't grow tomatoes, which takes us on to medical cannabis. So Hannah, you're doing a little bit of work in this area. I think yours is in the distribution rather than production, but whilst we haven't contributed to this funding, talk us through the issues of the clinical trials and what we're seeing from the medical cannabis trials.
Yeah, absolutely. So firstly, fabulous segue. Well done. So I have to admit, medicinal cannabis is not necessarily my core interest, but I started researching it really in response to a grant application or a grant call that was put out. And this was a grant call by the MRFF, which is a government funding organisation. And what they do quite well is that they engage with the community to understand what are the priorities in our community for where they want taxpayer dollars put in research. And there was a specific call that came from a consumer priority, which was identified around developing or generating better, high-quality evidence on medicinal cannabis to control the symptoms and side effects of cancer therapy. So I saw this call and I thought, absolutely, I have to apply for this. So I got a team together because I had no expertise in medicinal cannabis. I pulled together some pharmacologists, some experts in the space, and we proposed a clinical trial to generate some high quality evidence in this area because, and I have to admit, it's the best project because for once in my life, I'm not actually vying or excited for one way or another. I don't care if medicinal cannabis is effective or not. I want to generate good evidence that suggests one way or another. And so that, as a scientist, is such a nice situation to be in because you're not vested in one side of the coin. And I think the reason I'm so interested in this project is because if you go into the evidence, there's quite a bit of really high quality survey data that shows that more than 50% of people with advanced cancer turn to cannabis to control their symptoms and side effects. But the vast majority of these people are sourcing it on their own terms. So essentially they're getting illicit cannabis. if we go and talk to doctors and oncologists, they say about 80% of their patients ask them about medicinal cannabis, but less than 30% of oncologists know how to guide their patients appropriately. And this is because there is no good quality data out there. So essentially, we're really hoping to fill that big chasm in evidence and really show one way or another that cannabis is useful or is not useful in controlling the symptoms and side effects of cancer therapy. We're adopting quite a slightly unconventional approach in that we're taking in a big mixed group of people. Typically in clinical trials, it's very narrow. The indications of, it's a very small group of people that they're investigating. We're taking people with a myriad of different cancer diagnoses, undergoing various forms of cancer therapy, but these people are unified by the symptoms and side effects that they experience. And so we're giving patients and participants in our trial the opportunity to try different doses of cannabis, find which one works for them or does not work for them. And we're really putting the patient voice at the centre of this trial because we're using patient-reported outcomes as our primary measure. So this is patients telling us how they feel, not doctors assessing how their patient is behaving. And so I think it's a really exciting trial. It's been designed in collaboration with the community and with people who have lived experiences. And hopefully it will generate really robust data that will allow oncologists to guide their patients more appropriately. And if we demonstrate that it's effective, hopefully it means that people can access medicinal cannabis a little bit more easily and not from their neighbour down the street or something like that.
So I just want to sort of segue into something that's important to us and our supporters, and they want to see researchers collaborating so that there's no duplication and it's very effective and efficient outcomes. Can you, Renuka, and starting with you, Renuka, can you give us some examples of the benefits of collaboration?
Okay, so the project that I'm doing currently, the Avoid Frailty, so that's a nice example. So basically, the Canadians came up with the acronym. They've come up with the technology, so the web platform, to encourage behavior change. But in collaborating, we've helped them in thinking about new strategies. So like one of the investigators on our grant is from the University of South Australia, and she works with citizens. So she's very good with citizen science. So what we've done with citizen science, they've taken that on board in Canada. Similarly, we developed a frailty scale. So they've used that scale in their platform. So here is an example where, things that we are doing, we are sharing with them and they're taking it on board, and then vice versa, things that they are doing, we're doing here. So we're both actually sharing, and as a result of that, we're actually advancing faster than if we had actually competed with each other. Then we'll just be doing the same thing. But here it's like a relay. So basically, we do something, they take it on, then they do something, and we take it on, and it goes that way.
It's a really big part of translational medicine, isn't it, collaborating? And Stuart, I think you mentioned there's 10 or 12 collaborators around the world. You're using technology to share information. How impactful is that?
Oh, it's absolutely amazing. We have my student can get access to that Zoom link, join the meeting, and present his challenges that he's found in his project and get direct feedback from people that have been doing this for over 20 years. It's actually incredible. But I was just, while Renuka was speaking, I actually thought one of the best collaborations and that I'm fortunate enough to have is actually just access to surgeons across South Australia. My main trial at the moment is recruiting patients not only from the Royal Adelaide but Calvary, St Andrews, Western, and even the odd case gets moved to Ashford at the moment. So, those 12 surgeons that are actively participating in my trials, and the feedback they give me, then leads all the way down to my students that I'm supervising as well. So I'm just in a very lucky position at the moment.
Are they taking time to give you quantitative and qualitative feedback?
Some more than others, but they do. If they get their teeth into it, the feedback's amazing, and the quality of, if you give them a draft of a presentation or a publication, they will give you excellent scientific feedback, but also practical feedback. and ask more questions and really guide the next research question that student or myself have to go and then find out the answer for. It's actually really a two-way feedback mechanism.
So Hannah, you've recently been awarded, congratulations, an ARC, Australian Research Council grant, am I right?
An NHMRC.
NHMRC grant, National Health and Medical Research Council. Congratulations, that's a big deal. Part of that applications, all of the funders are now looking for what are you going to do from a collaborative perspective. How's it helped your research?
Yeah, I mean, collaboration is absolutely central to my entire philosophy of research. I think in supportive cancer care, where we're dealing with someone who has cancer, they have intensive and multiple forms of treatments that affect multiple organ systems, there's absolutely no way that I could ever expect that I could do it all. And I'm building a house at the moment, well, I'm renovating, and I think it's the same in a building sense. You know, there's no way that a plumber could build the frame, and they never would expect that they could do that. And I think sometimes in science we get a little bit excited, and we think that we can do it all. And there is this, you know, by nature we are all quite competitive people, and so that can sometimes bring out a little bit of the worst in us. We can want to do it all, but I completely disagree with all of that. I'm a true believer that I need to collaborate with people from all fields. So in my area, I work with neuroscientists, with microbiologists, with psychologists, with oncologists, radiation therapists, exercise physiologists. You name it, I'm sure they've got something that's relevant to supportive cancer care. And it's honestly the best part of being a scientist, is being able to engage with diverse people and really gain those diverse perspectives on a problem. You know, I think it's really easy to look at a problem with your own perspective, with your little tunnel vision, and not see opportunities that others will see in a project. And so that's what I've really valued through my various collaborative networks, both locally. So I'm based at SAMRI, the beautiful cheese grater building in the city. You know, it's this beautiful open plan area where I'm walking right next to the best neuroscientists in Australia, and I'm walking past immunologists, and you know, we can have these really natural conversations in the lobby or wherever. And that's where really great ideas are born, and truly this is where the foundation of my NHMRC fellowship was founded, was talking to someone in the corridors about what they analyse in saliva samples. And suddenly I decided, actually, I could apply that to my field, and so that's what we've started to do. So collaboration is absolutely central to my success, but also I think, you know, and not that I'm plugging, but I absolutely am plugging, you know, the Hospital Research Foundation has been critical in me being able to secure that fellowship as well. I applied for this same fellowship a couple of years ago, and I was unsuccessful. And, you know, that was the end of my contract, really. And so things were looking a little bit grim. I was a bit nervous about where I was going to end up. And Hospital Research Foundation have this great near-miss scheme. So essentially, if you'd applied for this fellowship and you were close, they come in and they scoop you up and they look after you for a few years while you get things back on track, and you know, build that track record, build that collaborative network, get those runs on the board so that next time you apply, you're more competitive. And hopefully I'm a nice example of how the Hospital Research Foundation can support people in that, you know, really scary time of instability, and result in having a little bit more stability for me and for my group moving forward now. So thank you, everybody.
Someone very smart said, "Where there's a will, we want to be in it." But there's a good reason for you, and of course, your popularity increased too when you started handing out cannabis. So you've heard everyone chatting about what they do in research, and we've got an opportunity now to take some questions. We've got, would anyone like to ask any of the panel questions? We've got a microphone over here. Yep.
There we go. It's a microphone.
Thank you.
How much for a stash?
I'll try and stand up. Thank you. First of all, congratulations to all three panellists. You've provided great insight into what you're doing, and I thank you very much. My question is to Hannah. As a retired radiation oncologist who's been retired some 17 years and who still keeps in touch with many of my old patients, you mentioned radiation oncology only at the end of when you're talking about collaboration. You hadn't mentioned it at all. Are you doing research into the side effects of radiation therapy, which can be quite severe?
Yes,
Thanks.
absolutely. We are. The radiation oncologists, I'm not sure why they came into my brain last, but they are very important collaborators of mine. So I work quite closely with Hien Lee at the Royal Adelaide Hospital, and we do some collaborative work together around radiation side effects. So the three that we're mainly interested in at the moment are oral mucositis. So we see this very readily in people with head and neck cancer who get quite intensive radiation to their face and to their neck, and this can result in very severe ulceration in the mouth, which makes eating and drinking and speaking very, very challenging. People are very embarrassed about how it looks and how it smells and all of that kind of stuff. It's a very debilitating side effect. So we're really interested in oral mucositis. We're really interested in the interaction between oral mucositis and cachexia as well, which is very severe and unmanageable weight loss. And recently we got some funding from the James and Diana Ramsay Foundation, which is another philanthropic funder here in South Australia, in collaboration with Sagenci, which is our South Australian Immunogenomics Centre. And we're testing a new formulation to protect the skin from radiation toxicity. So when people with head and neck cancer have radiation to the face, their skin can be burnt, and we're hoping that this new lotion will protect the skin. So yes, absolutely, radiation is a very important area for us.
And dessert will be out shortly, by the way. Yeah. Any other questions? One over here. Thanks, Gary.
Oh, thank you. Again, I congratulate the panel on your great efforts and contribution. So my question is to Stuart, and I'm sorry, it's not really focused around your area of emphasis, but, and I'm sorry, I've forgotten the statistic that you said a certain number of people within the first 10 years require revision surgery. For the people that are not within that category, so people that last more than 10 years, what's the expected duration or success rate for hip replacements?
It has, for a hip, you can, on average, you can almost get to 20 years and beyond. And that has changed even during my career and following all the survivorship stats. There was a major change in 2001. They introduced a new type of implant, and the hip is a ball and socket joint, and basically the plastic bearing that was put in, the material they used across all companies changed in the early 2000s. And a lot of my early work was measuring the wear of this material, and I measured 0 for years and years. And even now, I'm still following up those initial patients. We have 20-year data that shows they don't wear it all. Now, the big change in trying to predict how long your hip will last is patients done before that major change in the implant design. So patients done in the 90s would, on average, make 10, 15 years. Now we're looking at 20, 25 years. And yeah, that's the take-home message. The majority of patients having your first hip have really good outcomes. It's just the unfortunate patients that do have a complication, they have a cascade of events that they suffer from pretty much for the rest of their life.
Stuart, is it impacted at all by your type and level of activity?
It does a little bit, but activity is a very strange one, and national registries try and capture activity rates, but it's a one question on a form with 6 options, and even I don't know where I fit in those 6 options. So what we're doing is monitoring patients with wearable activity watches, like most people have these days, similar to Fitbits, but they're blinded, so you can't actually see your level of activity. We go a bit beyond just step counts. And what we really are finding is that patients that do well after revisions can actually get back to normal function similar to primaries. And no one's actually shown that activity level can get back to an adequate level if they receive the right implant, if the surgeon uses a current technique, and if they have a little bit of luck along the way that they don't have a complication, they can actually get back to normal, what we would call normal level of activity.
Mary Lou.
Would you like the microphone?
Sorry, there are three variables, Stuart: the patient, the implant, and the surgeon. Which component is showing up to be the biggest issue?
Not the surgeon.
Sorry, Stuart.
There's too many knowledgeable people in the crowd. We say a combination, but one of the best things that's began in Adelaide and is still in Adelaide is that for every implant put in a patient in Australia is tracked and kept a record of in the Australian registry. And we're really fortunate that we have 99% of Australians with an implant. We track whether they, the registry tracks whether they are reoperated on. And large-scale factors that you are talking about and comparison against implant designs, you can really look at that data at a larger scale in the national registry. What our trials are different, the registry doesn't look at the outcomes following revision hip replacement, and it does acknowledge they're poorer and it does give some basic stats for first-time revisions, but our patients are often second, third, fourth revision. Patient factors are often quoted in the registry and they're investigated, but you really do have to, there are a lot of limitations to that data, yeah, and it's multifactorial, and as you've just pointed out, the three main factors, probably a little bit of a mix of all three, yeah.
Is the surgeon listed on the registry?
So the surgeon has access to their own results. It's amazing. It's a great setup. It's owned by the Orthopaedic Association, so the members own the data. Researchers are allowed to access the data. Surgeons look up their own results and they can look up their own hospital results. And if you're flagged as an outlier with maybe poorer results, the Orthopaedic Association contacts you and they try and pinpoint possible reasons for that. So it is an incredible feedback mechanism, but I would stress it's on a larger scale, yeah. Yep.
Any other questions? Yes.
Thank you very much. My name is Jeff Murch. I'm 75 years of age, which in itself is a miracle, because if pussycats have 9 lives, I've had 19 lives. So I live in gratitude. Gratitude to doctors and hospitals and everything else. However, medically, I've had no luck whatsoever. I had a Depoy 40 chromium cobalt hip put in my body at Sportsmed in 2005 by a fellow called Roger Oakeshott, who now practices medicine in Lima, Peru, because Australia does not have an extradition treaty with Lima, Peru.
Well, I think we'll just...
Anyway, thank you very much. And, I'm very grateful to be invited here today, and I live in gratitude. So thank you all very much. Have a good life.
So, can you please show your appreciation to our panel? Thank you. Thank you very much for taking your time out of your busy days. We really appreciate it, and we'll give our hosts here an opportunity to serve dessert. So please stay around and enjoy the time and enjoy good fellowship and good company. And we can't do what we do to support these wonderful people without your support. So please think of us when you next speak to your solicitor about your will. Please think of us when you're thinking about how to do your monthly donations. We very much appreciate your ongoing support and thank you for coming.